Good afternoon, everybody, or good morning or good night, depending on where you are in the world today. My name is Associate Professor Anita Go, and I'm the Interim Director of Aged Care and Social Gerontology and a Principal Research Fellow at the National Ageing Research Institute. Welcome to our online Seminars in Ageing program. I would like to begin by acknowledging the traditional owners of the land on which each of us are meeting today, wherever you are. For me, that is the Wurundjeri Woiwurrung people, and I would also like to acknowledge the traditional owners of the lands and waters across Australia and pay my respects to elders past and present, and also to all Aboriginal and Torres Strait Islander peoples, including members of the stolen generations. I also have a few things to talk about regarding MS Teams. At the conclusion of the talk, we'll have some time for Q&A, and we really want your interaction and your engagement. So our speaker is very excited for that and is very happy for questions. So please submit them throughout the seminar using the Q&A function, which you see, for me, it's up the top. So it's a tab at the top of your screen, and it looks like two speech bubbles, one with a question mark in it. So we don't have the chat feature today, so please use that Q&A button to participate, and I will certainly monitor that for questions. If you prefer, you can also put your hand up, which is the little icon with the hand that says raise, and we can unmute you and freeze your camera. So you can ask it live if you would like to. Today's seminar will be recorded and uploaded to our website within a few days. So also please keep in mind, if you do turn on your video and microphone to ask a question, that your image will be included in this recording. Okay, so very excited and very honoured to be introducing our speaker, who is Dr. Sandra Iuliano. Sandra is a nutritionist and internationally renowned researcher from the Department of Medicine, here she is, at the University of Melbourne. She's a strong advocate for better nutritional care for older adults. Her work in ageing has focused on food-based approaches to prevent falls, fractures, and malnutrition in older adults, specifically those living in aged care homes. She led a 2-year study that involved over 7,000 older adults in 60 aged care homes that demonstrated that improving food quality can reduce falls, fractures, and malnutrition. She also provided input into the new single framework quality and safety standards for aged care and was summoned to present evidence at the Royal Commission into Quality and Safety in Aged Care, and is a member of the National Aged Care Advisory Council. Today, we're very lucky to have Sandra presenting on improving food quality reduces falls, fractures, and malnutrition in older adults in aged care. So welcome, Sandra, and over to you.
Lovely. Thank you, Anita, and thank you and welcome to everybody. Thanks for taking the time to come and listen to my talk today. Let me just get this up for you. Hang on. All right, there we go. That should not have started there. Let me just go back on that one. Here we go. That's it. I've just given out the secrets. All right. Look, thank you so much. I really enjoy presenting this work because as a nutritionist, I'm really passionate about food and food-based approaches. I think we often go to, pharmaceutical and nutraceutical means first, rather than going, hey, what do you like to eat and how can we accommodate that and the value of good nutrition. I often say, food is medicine, yes, and really everything starts in the kitchen. If the food's good, they eat, they're happier. So there's lots of benefits of good food for these older adults in aged care. So these are my disclosures, and also I need to acknowledge often I get the pleasure of sharing this work with you, but there was a huge unit of people behind me doing the work as well. So it's very much a team approach to any of these trials. As mentioned, it was 60 homes, so you can just imagine the size of the team. Normally I'd have photos up of everyone, but I actually ran out of space, and then the photos were so small you couldn't actually see the people. So falls and fractures, why are they important? So in the aged care setting, the rates of falls are 5 times higher than similar aged people in the community. So often people go to aged care because they are falling at home. So you've got a group of people that are very, very high risk. So if you can imagine, 1 in 10 goes to hospital each year. So that's kind of equal to 25,000 falls that are occurring that are ending up in hospital. So just to give you an idea from our trial, we reported 23,000 falls over a 2-year period. So that's a lot of falls. That is average 3 per person. The other thing is fractures. Now, my work started in osteoporosis and osteoporosis prevention, and often we don't know that someone has osteoporosis until they fall and they fracture. So you can see with this graph, now sorry it's so predictable, the blue are the males and the pink are the females, but you can see that when they get to around postmenopausal for women and around sort of 75, 80 for men, you can see the risk of fractures just goes up exponentially. So the average age in aged care is around 87. So this is a group that are at very high risk of fractures. And we know that most of the fractures that occur in this group are hip fractures. Hip fractures, they're costly, but also they're obviously devastating. And most within 6 months, they'll about half will have passed away. So it's not a nice ending to the life of someone who has had a long, full life, and it's a lot of pain involved. So it's not a nice way for people to end their life. Now, why aged care? About 6% of older adults live in aged care homes in Australia, so it's quite a small proportion, yet they contribute 60% to the total burden of fractures. Now, this data is from Australia, but it's almost identical around the world. So most around 6 or 7%, and yet we see that a third nearly of hip fractures come from aged care. So you can see the numbers that are going to be happening, 7,000 per year by mid-century. So that's about nearly 19 fractures per day. So a large number of fractures, which, we need to help prevent, because if we don't, the cost of these fractures perhaps will exceed the ability for our health system to cope. So if we do something with fracture prevention, it has to be something that everyone can access. It has to be inexpensive. It has to be safe. And also we need to know that if we're going to treat, all people in aged care, it has to be cost saving. Work was done using zoledronic acid, which is actually an osteoporotic medication. And using that was found not to be cost effective, but that was in an American system that have different health system to us. So let's go back to food. If we go back to our dietary guidelines, the dietary guidelines, now the reason I've got the meat and the dairy foods here are these are our protein foods. This is where we're getting good quality proteins from. So you can see with the meat food group, so that's meat, poultry, seafood, eggs, and lentils. It's about 2 servings per day and 2.5 for men, and you can see the size of the servings there. And for the dairy food, we know it's about 4 servings a day for women and 3.5. So this is for people over the age of 70. And you can see the number of servings there. So we've done some feasibility work, and residents can quite comfortably consume 4 servings a day. So this is what they should be getting based on our dietary guidelines. But this is actually what we're reporting in aged care in Australia. They're getting on average 1 serving from the meat food group and 1 serving from the dairy food group. So if you think from a protein point of view, very hard to get protein adequacy if they're not getting enough of the high protein food sources. So when we look at this, you can see they're getting about half the recommended servings from the meat food group, and they're getting about 1/4 from the dairy food group. Remember, this is a group that have really high risk of fractures, and one of the main sources of calcium in the diet is from dairy food. Now, dairy, milk, yogurt and cheese. Sorry for everyone who put ice cream in there. Ice cream is not one of our dairy food group foods, same as butter and cream. So it's the high protein, high calcium dairy foods that fit into that food group. So here we have a group of people that contribute a lot to our fracture burden. They fall, high rates of falls. We know they've got high rates of malnutrition. About 2/3 are malnourished or at risk of malnutrition. They have about half the recommended calcium intake. Protein intake's inadequate, about 0.8 grams per kilogram body weight, and they're getting about 1 serving of dairy per week. So if we look at recommendation, you can see that they're well below what they should be getting. And for protein, they're now looking at even higher than the Australian standard of about 1 gram. They're now suggesting about 1.2 to 1.5 grams per kilogram body weight to overcome, they term it anabolic resistance. So it takes more protein in order to get the same hormonal effect as a person who is younger. So I looked at this and my first question was, if we gave them extra dairy food, could we prevent falls and fractures? So it was a very simple question at the time. Took a long time to get the money and to do the project, but that concept of going, let's go back to something they know, foods they like, foods that they enjoy, foods that are familiar to them. Because remember, the majority now have some form of cognitive impairment. So it needs to be something they recognise. So that's when we embarked on this project. It was a 2-year project. We had 60 aged care homes. Half were randomised to providing extra dairy on the menu, which I'll explain in a moment, and the other half went about their usual food access from their usual menus. We monitored falls, fractures and mortality in all the residents for 2 years. And then we took a subset of residents and we actually did bone density, we looked at bone structure, we took serum, we did a whole host of assessments to hopefully understand the mechanisms. If we saw something, why was it actually happening? So I just need to share with you, we have bone density outcomes from people over 100 years of age. So how we did it, we worked with the food service staff. So we didn't tell them what to do. We asked the residents what they wanted to eat and what they liked. And then we worked with the food service staff so that we knew how they could do it. What was their kitchen like? What facilities did they have? Could they do it? And so therefore we moulded the intervention to suit the home and the residents, not the other way around. Here are some examples. We added it so that when they have morning tea, they had access to cheese and yogurts. We fortified milk with milk powder. We substituted instead of gravy all the time using cheese sauces, white sauces. And we also modified recipes so that we could increase the dairy content. So I've just put this up here to show you, so they're actually, as you can see, quite old, but the key point I want to raise here is if you look at the bottom line, that is their serum vitamin D level. Now we're suggesting around 75 nanomole per litre, and as you can see, they're vitamin D replete. This trial probably would not have worked if they were vitamin D deficient. We know now in aged care about 70% of residents we reported in our trial were getting vitamin D supplementation. Unless they're outdoors and getting sunlight exposure, it may be that all should be receiving vitamin D supplementation. Our foods aren't fortified, our dietary sources are insufficient, so it looks like supplementation would be the main way of ensuring vitamin D sufficiency. So here's the data. So this is the food data, and I present this first because if anyone knows with trials, if people are not compliant with an intervention, the intervention doesn't work. So the top left panel are the number of dairy servings, and as you can see, we got it from around just under 2 servings per day up to 3.5 servings, and you can see it was maintained for the 24-month period. So compliance was consistent. That's an absolute key criteria for any intervention. Our dietary calcium increased to around 1,100 milligrams per day per person, and that's the estimated average requirement, so we're achieving what we need to achieve. Their dietary protein went up from under 60 grams per day to 72 grams per day. It averaged at 1.1 gram per kilogram body weight, which is above the Australian recommendation, but just below what they're suggesting internationally. And the key thing is their energy intake didn't change. So 2 aspects. One, we were taking out nutrient-poor, energy-rich foods, discretionary foods, and substituting it for the dairy food. And also we know with older adults is they can't eat more food. So what we need to ensure is that with their limited appetite, what food they do consume is high in nutrients so that they're achieving the nutrient adequacy that they should be achieving. So this is the data. These are my graphs, the cumulative probability of an event. So when we look at it, every time a fracture occurs, the line goes up. So our blue is our intervention and our gold is, sorry, our blue is our control and our gold is our intervention. So you can see that for the blue, the controls, the line is steeper, which means more fractures. And we observed a 33% fewer fractures with intervention compared to the controls. When we look at the hip fractures, we observed a 46% reduction in hip fractures with intervention compared to controls. These became statistically significant, the divergence in the curves, at around 5 to 6 months. We also observed that bone density was maintained in the intervention group, and we also observed that bone resorption markers were also maintained but continued to increase. So we do have evidence to show potential mechanisms as to why we observed these reductions in fractures. So this is just some data looking at volumetric bone mineral density using high resolution PQCT. Again, the blue is our control, the gold is the intervention. And you can see that the bone density was maintained with intervention, but we saw around a 2% loss of bone mineral density in the controls, which is what we would expect in this age of people. So I always go, well, what does this mean? So if you can imagine, we're observing, so we know that their bones are porous because they're old, but what we observed is the rate of porosity in those bones was maintained with the dairy intervention, but we observed a thinning of the cortex and more porosity with in the controls. So if we have more holes in the bone and a thinner bone, it's more likely to fracture. So again, our intervention gold, our controls in blue, you can see that the curves are starting to part, and we observed an 11% reduction in falls with intervention. We also observed that the residents maintained their weight, their muscles in their arms and legs, and their nutritional status. And I'll show that data in a moment. The key thing here, if you look at the mortality, mortality was unchanged. So the first question we got asked giving them dairy is that you'll give them cardiovascular disease because of the fat content. But we actually looked at that and have published it. There was no effect on serum cholesterol levels. So what we were doing is stopping falls, stopping fractures. So these people were living the same life expectancy. Older adults in this group actually don't want to live longer, they want to live better. And we were enabling them to do that by falling less and fracturing less. So as I mentioned, if you can see, we can see there was a significant reduction in weight in our controls in blue, and that corresponded to loss of lean mass at the arms and legs as well as fat mass. So when older adults are losing weight, people, especially the majority of them, are overweight. So people just assume that, oh, that's okay, that they're losing weight. But in actual fact, they're not losing fat mass, they're losing lean mass as well as fat mass. Lean mass is function. I look at lean mass of the arms and legs, and that says to me how well they can get out of a chair, potentially how well they can stop themselves falling if they are about to fall. So with the nutritional status, we used the mini nutrition assessment tool, and we observed a 1-point loss, which was significant in the controls, and again, maintenance in the intervention group. And what the mini nutrition assessment score does is it categorises them into people being normally nourished, at risk of malnutrition, or being malnourished. And our intervention in the gold colours, you can see they relatively maintained their group. So if they were at risk prior, they maintained that category. Compared to our controls in our blue, you can see at baseline, which is the BL, compared to month 12, we can see that fewer people were in the normal nutrition group and more people entered the malnourished group. And this was significantly different between the two groups. We also observed that IGF-1 went up. So now we can see that it's not just the bone, it's not just the calcium, it potentially could be the proteins that was being provided through these dairy foods. So IGF-1 went up and was maintained in the controls. So we can see that there are a number of potential mechanisms that could explain what we observed. So the key thing is, and I say this, I suppose this is a piece of advice, is that when you're doing projects, it's really important to do health economic evaluations of them, because that is what can then translate it into practice. So we want to ask the question, is this cost saving? We fed them, we stopped fracturing, so is it cost saving? So this is to show you I suppose, the demographics of the fractures. And as you can see, the majority of fractures are hip fractures, and there's a lot of them. So 42%. Variety of different other fractures. And as you can see in the bottom right corner is the number of people that had multiple fractures. So some had 2, and as you can see, some had 4 fractures during the 2-year period. So this is work that's come out of Australia, and it looked at the cost of fractures. So it looked at the ambulance and hospital costs, it looked at rehabilitation costs, and then we took some data from the Netherlands to look at the care costs in the year that they go back to the care home. Now I've highlighted this key thing. As they get older, you can see that the cost is generally higher. And also you can see that the cost for women is generally higher than men. Now remember, most of these people are old, so the cost is going to be higher, and majority, about 75%, are women. So I'm just going to explain this to you very quickly. This is when we average it out per person. So the intervention cost was around $248 per year, and I'll explain that in a moment. When you take the hospital, ambulance and rehabilitation costs, it averaged out around $522 per person and $930 in control. So if you go over to the difference, that's $408 less. The same's done for residential cost. So when you add up those costs, so the cost of the food is a positive, and then the reduction in hospital costs and care costs, we see a difference of $175 per person in a care home. So when we look at that overall, it comes out at a saving of around just over $8,500 for every fracture that is prevented in a care home. So just to give you some context, this intervention cost 66 cents per day per person. And one of the key things is how much can they spend until it stops becoming cost saving. And in this particular case, it can go up to about $1.07. So this was done when milk was around $1 a carton. So what we'd need to do now is translate that to what's happening to the cost of foods now. So even then, if we went up and basically nearly double the cost of what we paid, and it can still be cost saving. And that averages out to over $66 million across Australia. Now remember, the population's ageing, more people are going to go to care, so the likelihood is that this cost is only going to go up. So the key for me is implementation. So it was wonderful. I had this beautiful team of people. We did this fantastic work. We showed fracture reduction, falls reduction, slowing of loss or nutritional status, slowing of the decline. We showed it was cost saving, all these great things. But what this has enabled me to do as a representative of our group is I was able to provide evidence at the Royal Commission. So I was able to put nutrition on the map. There are a lot of problems in aged care, and there was a lot of people that were sort of lobbying for their point, and I was quite happy that food nutrition featured quite highly. Because of giving evidence, I then became or asked to become a member of the National Aged Care Advisory Council. So now there was this ability to really change policy, because the only benefit of that research is if we can change policy and practice. So two things have come about. One is that we actually have nutrition mentioned in the new aged care bill that has been passed through Parliament. That is a huge plus, because prior to this, it wasn't mentioned at all. We also now have a food and nutrition quality standard, so we can actually get quite specific about what we expect from aged care providers in providing food and nutrition to their residents. The bill is resident focused. How we care for our residents now is resident focused. And if I go over to the sort of far left corner, what I'm trying to aim at is minimal nutritional standards, because it's difficult to know if a menu's okay if we don't have a benchmark to compare it to. And the key thing is that, those two meals are meals that we actually monitored in aged care homes. And for me, I don't want to see those meals offered any longer. What they should be getting is good, nutritious food that they actually enjoy and want to eat. So in conclusion, just improving the food quality. We know that they're inadequate. We're able to cost effectively reduce fractures and falls. And so in a sense, if you look, there was this gradual decline in the controls. And one of the key things I say is malnutrition is not a normal part of aging. So we slowed that decline. You saw that it was an inexpensive intervention. And, I think when we look at falls and fractures, we need to look at the whole methods, the number of ways we can help reduce falls and fractures in these people. And again, this work has enabled me to guide policy to improve the nutritional care of older adults in aged care in Australia. So with that, thank you very much, and I look forward to our Q&A session. There are my details there. And again, I look forward to. So thank you very much for the wonderful opportunity to present this work.
Thank you, Sandra. Amazing. I mean, we always talk in research and practice and policy about impact. And I think you took us on quite the great case study of how research and evidence can be used to create impact into people's lives. So that was very inspiring. Thank you. So everybody, please engage with Sandra in asking some questions. So if you have any questions, again, please submit them to the Q&A function, which can be opened in that tab up the top that looks like two speech bubbles. Remember, the chat is disabled, so please don't post there. You won't be able to. And alternatively, if you would like to ask a question in person and live, please put your hand up and we can unfreeze you and unmute you. So there is a question at the moment in the chat from Natalie Kothar about how the recommendations and approach of this project applies to culturally and linguistically diverse communities.
Yeah, fantastic. One of the key things, I'll just give you an example. When we did the intervention, we did have some ethnic specific sites. And so we then tailored the intervention to that site. So I think that we need to cater for our culturally diverse population. And with dairy food, if dairy food is a normal part of their eating, then I think you can more than comfortably incorporate it into the menus that they provide. The key is it's what they wanted to eat. So if it's part of their normal eating, then I think we quite comfortably achieved the intake in ethnic specific sites too.
Yeah, I think the part where you said you asked about foods that were familiar and food that they like was really kind of answered that question for me that I was thinking as well, because you want to tailor the food that people will actually eat and provide quality of life, right?
Yeah. The other part also, just to add to that, is most have some form of cognitive impairment, and a lot do have dementia. And so often you find that they don't recognise certain food. So, for example, I'll give an example, a Tetra Pak. They may not know what a Tetra Pak is because it was never part of their life, 80 years ago. So we found that they could recognise the food. So if you gave them a piece of cheese, they actually knew what it was and ate it accordingly. So that's the other aspect of it. It's tastes, it's textures, it's smells, it's foods that they do recognise compared to perhaps foods that aren't in a packaging that they would normally know.
That makes sense. We'll go to a live question now. Associate Professor Frances Batchelor.
Thanks, Anita, and thanks, Sandra. As always, a fantastic presentation. I guess, it takes time, doesn't it, to get evidence into practice, and you're doing that in an amazing way by trying to influence policy. But do you get the sense that that organisations are changing? Like, is it filtering through, or is it still kind of hard work and needing more of the stick approach?
Yeah. Look, really, really good question. As people may or may not be aware, aged care is absolutely going through the most, I suppose, substantial reform that it's ever been through. So there are lots of fronts that are being tackled. And so we have data, we've collected data. So in terms of the question, I'll have evidence which we're currently analysing to know food's got better now. But July 1 is when the new Act comes in, and therefore there's going to be a requirement. So no longer can we say it's okay if the food is substandard, there will be a requirement, and it's the same as the food nutrition quality standard. So the benchmark is changing, and so really for me, it's not about saying how do we support them to be able to get to those levels, those standards. And that's why I was saying with the quality, the minimal nutritional standard is that benchmark that we can use. If they're above it, fantastic. If they're below it, how do we support them to get up? It's not about, hitting them over the head if they're not getting it right. It's about what can we do to support them? What do they need to be able to provide more nutritious foods for their residents?
And do you think thank you. Do you think that, what are some of those barriers that you've come across? What do they need to be better supported?
Yeah, look, we've done work with this, and the key one is financial. That's the biggest budget. The budget is the biggest issue we see. The second thing is lack of nutrition knowledge across the board. So if you look at most of the courses, they don't require nutrition in the courses. So you've got care staff who observe food not being eaten but don't understand the consequence. You've got food service staff that are producing food. They're doing it as they think is the best for the resident, but it may not be nutritionally spot on yet. So lack of education and financial and time. If you think one of the key problems is eating assistance, and so more staff enables staff to spend more time, because food should be fun and eating should be enjoyable. It shouldn't be a task that if you're providing eating or feeding assistance, it's just a task, whereas it'd be nice to be able to slow it down and let them enjoy their food, because if they enjoy it, they eat it.
Yeah, and I really like that you highlighted it's a multi-sensory experience, isn't it? Eating food. Thank you so much, Sandra.
You're welcome.
So speaking of barriers, we've got a question from Kylie Bennett in the chat as well, in the QA, about what other screening tools would you recommend for identifying malnutrition, as the M&A for use in practice has a cost?
Yeah, that's a tough one. There are other tools, and look, that's a tough one. I don't know. Each have their limitations. And I'm just interested to know what the cost for the M&A is. Is it labour that you're considering? Or I'd be interested, Kylie, if you can pop something in there, because we observed yes, there's staff cost in terms of, but our staff were actually performing the anthropometric part. But is it just staff time doing it? That's the issue. That would help me out a little bit. Kylie, if you can answer that one, if she's around still.
I'll let you know if she pops it in.
Yeah.
So one more online question and then we'll go to a live question. There's one from Aisha Kanawi. Is there research being conducted into the effect of nutrition on cognition?
Look, there has been quite a lot done. There have been some interventions done, I think, with B group vitamins, not necessarily at this scale because it's difficult at this scale to look at food. As you know, it's an expensive trial, but there have been specific components that they've looked at in terms of vegetable consumption, B group vitamins, etc.
Thanks, Sandra. Okay, Tuan, there you are. Ask your question.
Thank you, Anita. So thank you, Sandra. And sorry, I missed the first half of your presentation because of another meeting. But I know that nutrition is very important on our life, and it impacts the malnutrition is impacting on a lot of things. My question is more like the practical things. I know your participants is from aged care. Resident care facilities, right? But how about the communities? How can we know people in the communities, older people in communities, they got the malnutrition status, and what is the kind of like the recommended amounts of different type of nutrition, like fibers, vitamin, etc., and how we can help the older people in communities?
Yeah, look, that fantastic question because they're hidden and we often don't know until they present to hospital. So the problem could be worse still. One of the things that's currently happening is they're looking at the home care packages so that keeping people at home, and I'm having some input into that so that the nutrition, if they're getting food provided for them, that it's of a good nutritional value. It's a difficult one because we've got to always consider people in their own home. Each person has a different background in terms of cooking skills, each have mobility, whether they can access the food, financial, can they afford the food? So hopefully with those that are receiving care from the home care packages, we can at least ensure that they are getting whatever food, there's a standard to it so that we know that it's meeting at least the nutritional value for that particular meal, if that makes sense. So if they're getting one hot meal, they should be getting at least a third of their nutritional requirements from that meal.
Thank
so
you.
it's a tough one in the community.
Yes, and you know, so even with the people who receive the home care package, it's still like the part of the population, right? Because still a lot of older people who receive care from their family alone and without any home care package, and they still have the problem with the nutrition and how to improve the knowledge of the families. Even with me, I don't know what to prepare for my parents, and to be honest, what is the kind of like the requirements amount for individual visual substance in a meal that is relevant for parents at, for example, 80 years old. So yeah. I don't know how we can do it at the communities level for the whole population.
Look, it's a really good thing, and I agree there needs to be more access to information and more knowledge provision, and also the practical components of it so that people from all backgrounds can access the information. So for older adults, the key nutrients that are greater than for younger adults is the protein, vitamin B6, calcium. Okay, they're probably the three main ones. And so that's why I suppose for us the dairy, because it was the protein and the calcium which were the key one. The other one's vitamin D as well. But that usually has to come from supplementation. But I think we need to sort of step back as a society and go, how are we treating our older adults and what do they need, and what should we be doing to kind of provide for their nutritional needs?
Yeah, I mean, that kind of brings us, thanks, Tuan, and a question from Vicky Ho in the chat as well. It says, it's interesting that the focus is on protein and not vegetables and fruits.
Yes, the reason being, thank you, very good question. So I'll tell you why. If you look at fruit consumption in aged care, the requirement is about 2 servings a day. They're getting 2 a day. When you look at vegetables, they're getting 3 servings per day, and that's aligned with pretty much the rest of Australia. But it was more the fact of the protein food. So they were getting 50% of their meat servings and 25%. So if you were to go distance from recommended, the worst one was the dairy food because it was furthest from recommended. And let's go the other way. When we look at discretionary food, 6, 7 servings a day, and that should be 0 to 2. So what we're seeing is a move away from these higher nutrient-rich foods into these nutrient-poor, high-energy foods. So it fills them up, but it's not providing any nutritional value for them.
Great, that was a very clear answer. We have more information from Kylie about the cost for the MNA.
Thank you, thank you.
It's the owner charges to use it on the clinical management system.
Oh, there you go. That's some, Kylie, thank you.
Yeah.
That's
Yes.
something I didn't know that. So there you go. Thank you.
And a question from, oh, sorry, go ahead.
GLM, there are others. There's GLM. I'm interested now. Kylie, you sparked my interest here. Even the short form. So I find that just we need screening across the board. Like that's one thing we don't have in Australia, where they're screened on entry. That should be just a standard procedure. They're screened on entry, then you have a benchmark if they're okay or not okay. And then we go from there. So if they're at risk of malnutrition or malnourished, you put the plan in place, but also you monitor them more regularly. So that's I'd be very interested to talk to you about that because I wasn't quite aware of that.
No, this two-way interaction is fantastic.
I'm learning.
Exactly. There's a question from Ashley Lamming about residents on modified texture diets. Were they included or were there considerations made for those people on modified texture diets?
Yes, they were included as well because we did it across the entire facility, or the whole home. What we do have observed, and this has been observed overseas as well, is that generally the nutritional quality of the texture modified, I'm going to go all the way to pureed, because if it's been cut, it's just the same food, but cut, the pureed generally is of lower nutritional quality than the standard food. Often it's because it's been diluted slightly. And I have horror stories I can tell you about texture modified food, but generally it's because it's slightly diluted. So they are at greater risk still than people who are.
Can you swing around and answer Bianca's question about protein supplement shakes then? Does that relate to what you were just talking about?
Look, I haven't seen, but Bianca, the protein supplement shakes, in a sense, what we were doing, we were making smoothies, we were making milkshakes, but instead of using a commercial protein, we just use skim milk powder. And the reason being is that, I mean, I have a daughter that consumes, her little protein stuff. And I'm just going to give you an example. A kilo of skim milk powder costs about $10. I'm looking at her little bucket of protein stuff and it's about $40. Same. So the protein powders often have other nutrients added to it, I'll give that. But we found in aged care, the key thing that was inadequate was protein, calcium, and minor zinc. So all the B groups and things that they may add in, they were actually okay. So protein powders are good, but they're expensive, more expensive than using just a regular skim milk powder.
Fantastic.
Yeah.
That's a great response. 2 more questions, if that's okay with you, Sandra.
Yeah, no,
I know we're asking a lot. There's a question from Catherine Milty about, could you provide more detail about the steps to getting nutrition mentioned in the aged care bill? Was this challenging considering the number of other issues to address in the aged care space?
I think I'm going to just say tenacity, and I was just very persistent with it because it was critical that it was mentioned, and perhaps through I'm privileged enough to be a member of the National Aged Care Advisory Council, and so I actually had a direct line to government, so I could keep. And basically, the key thing is that when I talk, I'm not talking my opinion, I'm presenting them data, and I'm talking on behalf of research. And that was the value of it, because one thing you can't do is you can't argue with data. You can argue against an opinion, but not with data. So I was very persistent with it, I think. And I'm quite passionate about it. And because I don't have to represent an organisation, I can just represent my data and go, this is what happens if you improve nutrition. So that for me was a huge plus. That was probably one of those benchmark tick points where you went, wow, we're finally going to make inroads here. So I think just tenacity.
Yeah, and you clearly don't lack passion and knowledge about this topic. But I think Catherine's probably nodding along with the use of evidence, because she'll be very familiar with that. All right, one last question. Paul Knight is asking about any recent or similar studies on nutritional interventions for falls prevention that have been based in the community as opposed to aged care.
Do you know what? I only have, off the top of my head, there are only 2 that I know of. No, there are a couple. One was from transition from hospital to home, and one was successful, one wasn't. The successful one started the treatment. They used enhanced diet while they were in there, but then they used nutritional supplements after they had been discharged, but they also had calcium supplement and vitamin D supplements. And now it's like, oh, I'm not sure what's working here. The key thing, and back to the point I made earlier, is that trial was successful, I think, because they continued to monitor the people. And so therefore compliance was good. Compared to the other trial, which was a similar setup but was unsuccessful, they were discharged with the supplementation and no follow-up. And I think compliance off the top of my head was like 40%. If you're having a bit of something, it's not going to work. So I think the key thing is, even in the community, if you are doing things, you have to ensure compliance. Otherwise, and that's harder in the community because people, if they do have cognitive impairment, you don't know if they've consumed it, you don't know if they've stored it well, you don't know what they've done to it. They could have fed it to someone else. We don't know, so it's a much harder group to tackle.
Exactly. I'm going to squeeze in one more question. I promise it's the last one, Sandra.
That's okay.
Is B12 often supplemented for vegetarians?
Yeah, usually it is, because they just can't get enough. They just can't get it. I think in mushrooms you can get it a little bit, but probably not enough. Also, some people have issues with the factor. So some people actually then need a B12 injection. But yes, definitely needs to be supplemented in a person that is vegan. Vegetarians, maybe. But the key issue would be, as they're getting older, their ability to absorb would be reducing. So often they do need supplementation.
Thank you very much, Sandra. I mean, that was so much amazing information and research and evidence, and a really great illustration into how your work can make a difference in the lives of older Australians and people around the world. So really, thank you so much. And everyone here, if you can please join me in thanking Sandra with your clap reactions. That really, I learned a lot.
Thank you. They're in 3D. Our claps are in 3D. That's gorgeous.
Technology has come along.
It has, hasn't it?
So next month, we have Professor Hanan Khalil will be presenting on the development and implementation of the Palliative Care Assessment Toolkit for rural aged care facilities in Australia. So please join us on Tuesday, the 25th of March for that. And everybody, thank you so much for attending the Seminars in Aging series, and have a lovely afternoon and rest of your day.